Hello, welcome to Oncology Innovations, TNBC, Bridging Gaps in Care for the Black Community. I am Tabitha Washington with DKB Med. Our faculty today is Rita Nanda, Director of Breast Oncology and Associate Professor of Medicine with the University of Chicago. Okay. And here are our faculty's disclosures. This educational activity is supported by an independent educational grant from Gilead Sciences Incorporated, jointly provided by Partners for Advancing Clinical Education and DKB Med LLC. All activity content and materials have been developed solely by the planning committee members and faculty presenters. Here are our educational objectives. Discuss the evidence supporting molecular testing in advanced triple-negative breast cancer. Assess the efficacy of treatment options for those with metastatic triple-negative breast cancer. Apply best practices for managing treatment-related adverse events associated with therapies for metastatic triple-negative breast cancer. And now we'll turn this presentation over to Dr. Nanda.
Thank you for that introduction, Tabitha. Triple-negative breast cancer accounts for about 15% of all breast cancers and is defined by lack of expression of the estrogen, progesterone, and HER2 receptors. Triple-negative breast cancer is a very heterogeneous disease and has a tendency to be very highly proliferative and aggressive. While these tumors can generally be very chemotherapy responsive in the frontline setting, unfortunately, resistance rapidly develops. Triple-negative breast cancer, when metastatic, has a propensity to metastasize to the lungs and the liver, and about 50% of patients with metastatic triple-negative breast cancer will develop brain metastases over the course of their metastatic journey. Median survival is generally under 2 years from the diagnosis of metastatic disease, and we know that triple-negative breast cancer has a propensity to affect certain populations with higher incidence. Those individuals who have BRCA1 germline mutations, Black women, Hispanic women are at higher risk for developing triple-negative breast cancer than other groups of patients. There is an uncommon indolent subtype of triple-negative breast cancer, which is generally androgen receptor positive and has a tendency to occur in older women. But again, this forms a minority of triple-negative breast cancers. When we look at overall survival by stage, you can see here in the orange lines that triple-negative breast cancer, even if caught early in the stage 2 and 3 setting, is associated with the poorest survival as compared to other breast cancer subtypes. And that's true of advanced stage triple-negative breast cancer as well. So even though we've made recent advances in the management of triple-negative breast cancer, we know that this form of breast cancer still behaves more poorly than other forms of triple-negative breast cancer. Over the last few years, however, we have developed some targeted therapies for advanced triple-negative breast cancer. The immunotherapy drug pembrolizumab, which is an anti-PD-1 therapy, is available for use for PD-L1 positive metastatic triple-negative breast cancer. For those triple-negative breast cancers that are associated with alterations in BRCA1 and 2 in the germline, olaparib and talazoparib have been associated with improvements in outcomes. And then the two antibody drug conjugates, trastuzumab deruxtecan, which targets HER2, and sacituzumab govitecan, which targets TROP2, are also available for use for advanced breast cancers. Trastuzumab deruxtecan, or TDXD for short, is available for use in HER2-low breast cancer as well as HER2-positive breast cancer. And then sacituzumab govitecan, or SG for short, is available for use regardless of expression of TROP2 levels in the tumor. And so we'll review some of those data as well. When we think about triple-negative breast cancers, we know that when we do expression profiling, which isn't done clinically, but rather in the research arena, that triple-negative breast cancers can cluster within 4 distinct subtypes. And this research has led to the development of some of these targeted therapies for these different subtypes of advanced triple-negative breast cancer. When we think about biomarkers and what we want to test patients and their tumors for when they're diagnosed with advanced triple negative breast cancer, I think it's really important to recognize that there are a number of biomarkers that can help us with selecting the appropriate therapy for how to treat patients. We know that triple negative breast cancers that express PD-L1 are responsive to immunotherapy with drugs like pembrolizumab. Pembrolizumab plus chemotherapy has been shown to improve outcomes as compared to chemotherapy alone for PD-L1 positive triple negative breast cancer. We know that individuals who have germline alterations in BRCA1 and 2 are candidates for olaparib and talazoparib. Sacituzumab govitecan is available for use for all forms of advanced triple negative breast cancer, and in fact, hormone receptor positive disease as well. And then trastuzumab deruxtecan was first approved for HER2 positive disease, but now has an indication for HER2 low disease. By that, I mean HER2 IHC1 plus or 2 plus. There are a number of therapies that have tumor type agnostic indications. So larotrectinib and trectinib and repotrectinib are all available for the management of cancers that are associated with NTRK fusions. This is pretty uncommon in breast cancer. We know that tumors that are characterized by mismatch repair, microsatellite instability, high tumor mutational burden. We have immunotherapy monotherapy that is available for use. And then for those tumors that are characterized by RET fusions, selpercatinib is available for use. But again, these tumor type agnostic indications target fusion proteins and abnormalities that are relatively uncommon in advanced breast cancers, including advanced triple negative breast cancer. But again, it's very important to perform next generation sequencing to look for these rearrangements and fusions, because if we don't look, then we don't have the opportunity to treat patients with some of these life-extending therapies. I'd like to now review some of the data that led to the approval of some of these targeted agents for the management of triple negative breast cancer. The Keynote 355 trial was a randomized phase 3 trial, which investigated the addition of the anti-PD-1 agent pembrolizumab to chemotherapy for advanced triple negative breast cancer. In this clinical trial, almost 900 patients with metastatic triple negative breast cancer were enrolled and randomized in a 2-to-1 fashion to pembrolizumab versus placebo plus chemotherapy. This was a frontline trial. Patients could not have previously received treatment for their metastatic triple negative breast cancer, and patients were eligible regardless of PD-L1 expression, but it was a stratification factor. Patients were stratified based on whether or not they were PD-L1 positive or not, whether they'd previously been diagnosed with early stage disease and had therapy in the early stage setting or not, and then which chemotherapy they were randomized to in the context of this trial. This trial allowed the physician to choose the chemotherapy backbone, and the chemotherapy consisted of either paclitaxel, nab-paclitaxel, or the carboplatin and gemcitabine doublet. There were dual primary endpoints looking at progression-free survival as well as overall survival in the overall intent to treat population, as well as in different categories of PD-L1 positivity. Those with higher degree of PD-L1 positivity, a combined positive score of at least 10, and those with a lower level of a combined positive score of at least 1. What we found in this trial was that there was a significant 4-month improvement in median progression-free survival for those patients who had a combined positive score of at least 10. And that truly is the cut point for determining which patients are eligible for immunotherapy to be given in combination with chemotherapy. Those patients who had PD-L1 lower level of expression did not benefit significantly from the addition of pembrolizumab. So it truly is a combined positive score of at least 10 that is the cut point for those patients who are eligible for the addition of pembrolizumab to chemotherapy. In addition to the 4-month improvement in median progression-free survival, there was an almost 7-month improvement in median overall survival for this patient population. So this has solidified the role of pembrolizumab plus chemotherapy for patients with metastatic triple-negative breast cancer who have a PD-L1 positive tumor defined as a combined positive score of at least 10. Immunotherapy does come at the cost of immune-related adverse events, and it's very important to have a very low threshold for thinking about immune-related adverse events for patients who are receiving immunotherapy. Immunotherapy can work by stimulating the body's own immune system to attack the cancer. And as you can imagine, sometimes when there's an overactivation of the immune system, we can see autoimmunity. And this can affect essentially any organ in the body. Some of the most common toxicities here are outlined in red. Of the endocrinopathies, hypothyroidism is quite common. And so it's very important to think about testing thyroid function periodically for patients who are receiving immunotherapy. Arthralgias, myalgias, rash, pruritus, diarrhea, all quite common. And it's very important to recognize these immune-related adverse events and manage them appropriately. And we'll talk a bit more about that in the latter half of this talk. Now, shifting gears to review the data which led to the approval of the PARP inhibitors for BRCA1 and 2 associated advanced breast cancer. The Olympiad trial was a randomized phase 3 trial which investigated olaparib versus chemotherapy of physician's choice for individuals with HER2 negative metastatic disease. In this trial, patients who had BRCA1 or 2 deleterious mutations were randomized in a 2-to-1 fashion to olaparib versus chemotherapy of physician's choice, and those chemotherapy options included capecitabine, eribulin, or vinorelbine. To be eligible, patients must have received 2 or fewer prior lines of chemotherapy for advanced stage disease. And what you can see here is that olaparib was associated with a significant improvement in median progression-free survival, an almost 3-month improvement over chemotherapy. And what I have not shown you here, however, is that olaparib was also associated with a much better quality of life. So not only is olaparib more effective than chemotherapy of physician's choice, it is associated with a more favorable quality of life. This trial did not demonstrate a significant survival advantage, but again, a significant 3-month improvement in median progression-free survival. In reviewing some of the toxicities that were seen, hematologic toxicities were the most common. The vast majority of toxicities seen in this trial were grade 1, with anemia and neutropenia having slightly higher rates of grade 3 adverse events. But again, these were quite manageable with either implementation of systemic dose reductions or, in the case of nausea and vomiting, antiemetic therapies. So again, olaparib was just generally very well tolerated. The vast majority of toxicities were grade 1 and 2 and easily manageable and did not require treatment discontinuation, although some were managed with dose reductions. The Embraca trial was a very similarly designed randomized phase 3 trial which evaluated talazoparib versus chemotherapy of physician's choice, very similar design to the Olympiad trial. Here, talazoparib versus chemotherapy of physician's choice, which were really quite similar to what we saw in the Olympiad trial with the addition of gemcitabine. So capecitabine, eribulin, gemcitabine, or vinorelbine. The primary endpoint of this trial was progression-free survival. And what you can see here is that the trial did achieve a statistically significant improvement in median progression-free survival of about 4 months. There was not an overall survival, but just like the Olympiad trial, the talazoparib was associated with a significant improvement in quality of life as compared to chemotherapy. So again, we've got 2 PARP inhibitors, olaparib and talazoparib, which are approved for use in BRCA1 and 2 associated advanced breast cancer. Talazoparib had a slightly different side effect profile than olaparib, a little bit more in the way of hematologic toxicities here, more anemia, neutropenia, thrombocytopenia as well. But again, the majority of these toxicities were grade 1 to 2 and easily managed. A bit more fatigue, nausea, and vomiting here. But again, the vast majority of these toxicities were grade 1. They are manageable with either dose modifications or the addition of antiemetic agents. The olaparib expanded trial, or TBCRC 48, was a trial which looked at olaparib monotherapy in patients with advanced breast cancer. It investigated a number of cohorts of patients who had DNA damage repair pathway abnormalities, as well as germline abnormalities in some of these genes. Here you can see that in those patients who had germline PALB2 mutations, olaparib was a remarkably effective agent when given for the management of advanced stage disease. You can see here that the response rate was 75%, really impressive waterfall plot here with a clinical benefit rate of 83%. And responses were seen regardless of receptor status. You can see that triple negative breast cancer, hormone receptor positive breast cancer, as well as HER2 positive breast cancers all potentially benefited from olaparib therapy in the setting of a germline PALB2 mutation. This trial also investigated somatic BRCA1 and 2 mutations. So again, not all that common, but can certainly be seen in a proportion of patients with metastatic disease. And what you can see here is that the response rate was almost 40% for patients who had somatic BRCA1 and 2 mutations with olaparib, with a clinical benefit rate of over 50%. And again, responses seen in various receptor subtypes, including triple negative breast cancer, as well as hormone receptor positive disease. And so it is certainly reasonable to think about olaparib therapy in those individuals with metastatic breast cancer in the setting of a germline PALB2 mutation or somatic BRCA1 and 2 alterations. Shifting gears to touch base on 2 of the antibody drug conjugates, which are currently available for use for advanced stage disease. I'd like to start just to show you a little bit about the history of antibody drug conjugates. As we think about the antibody drug conjugates and how they've recently transformed the care of a variety of different advanced cancers, including breast cancer, you can see this idea of targeted chemotherapy was first thought of over a century ago. And it did take about a century for us to have the first approval for an antibody drug conjugate for advanced breast cancer, with the approval of TDM1 for HER2 positive breast cancer. Since then, we've had the approval of trastuzumab deruxtecan for both HER2 positive as well as HER2 low disease, and sacituzumab govitecan for both hormone receptor positive as well as triple negative advanced stage breast cancer. When we think about antibody drug conjugates and how they work, you can see here that antibody drug conjugates consist of an antibody which binds to a receptor on the surface of a cancer cell that is chemically linked to a toxic payload. So as the antibody drug conjugate recognizes this surface antigen, it binds to it, can become internalized in the context of a lysosome, and then the toxic payload can diffuse or disassociate from the antibody and lead to apoptosis of this cancer cell. A number of next generation antibody drug conjugates have something called a bystander effect, which refers to the concept that the toxic payload is stable even outside of the cancer cell and can diffuse into neighboring cells, which may not even express the antigen being targeted and lead to killing of those cancer cells as well. Furthermore, some antibody drug conjugates can release their toxic payload simply on binding to the antigen on the surface of the cancer cells and do not even require internalization. This potent bystander effect is what has led to the approval of a number of agents which target a lower degree of antibody drug conjugates on the surface of cancer cells, such as the case of HER2 low disease, and has led to the remarkable efficacy of antibody drug conjugates. Sacituzumab govitecan is a TROP2 targeting antibody drug conjugate. So the antibody targets TROP2, which is ubiquitously expressed on the surface of a number of different epithelial malignancies, including all forms of breast cancer, hormone receptor positive, as well as triple negative breast cancer, and is chemically linked to SN38, which is the active metabolite of irinotecan. The toxic payload matters because the toxic payload determines what the side effects may be of these agents. So as you can imagine, because SG's toxic payload is SN38, or as I'd mentioned, the active metabolite of irinotecan, it shares a number of toxicities with irinotecan, including diarrhea as well as neutropenia. And so I think that that is very important to think about these toxic payloads because it helps us predict what side effects we may see in patients. SG was first granted accelerated approval in 2020 and then was granted full regulatory approval based on the randomized phase 3 ASCENT trial. In this trial, almost 530 patients with metastatic triple negative breast cancer were enrolled and randomized to SG versus chemotherapy of physician's choice. You can see these are the same 4 chemotherapy drugs that were used in the EMBRACA trial. In this trial, patients needed to have received 2 prior lines of chemotherapy for advanced stage disease. However, if patients had had therapy in the early stage setting and who recurred within a year, then that counted as a line of therapy. The primary endpoint of this trial was progression-free survival, as well as a number of secondary endpoints, including overall survival. And what you can see here is that the ASCENT trial met its primary endpoint of demonstrating an almost 4-month improvement in median progression-free survival, favoring SG versus chemotherapy of physician's choice. And this translated into a more than 5-month improvement in median overall survival, favoring SG. And so based on the ASCENT trial, sacituzumab govitecan is now FDA approved for metastatic triple negative breast cancer, and it has subsequently been approved for metastatic hormone receptor positive breast cancer as well. So as you recall, the active metabolite of irinotecan, SN38, is the toxic payload for SG. So not surprisingly, neutropenia and diarrhea were 2 of the most common side effects that were seen here. The vast majority of toxicities observed were grade 1 to 2. However, about a third of patients did develop grade 3 or more neutropenia, and about 10% of patients with grade 3 diarrhea. These toxicities, however, did not lead to early discontinuation of these therapies, but rather dose modifications or the institution of supportive care, such as growth factor or antidiarrheal agents. SG has also been evaluated in different racial and ethnic groups. About 12% of the patients who participated in the ASCENT trial were of self-reported Black race. And when we looked at median progression-free survival as well as median overall survival in those 12% of patients who were Black, you can see here that we saw very similar improvements numerically in terms of median progression-free survival and overall survival, demonstrating that Black patients derived a similar benefit with SG as did the overall intent to treat population. The safety profile also was very similar, with neutropenia and diarrhea being the 2 most common toxicities, but again, quite manageable with supportive care and or dose modification. SG was also evaluated in the context of TROP2 expression levels, both in terms of overall survival and response rate. And I know this is a very busy slide here, but the bottom line is that patients benefit from SG over chemotherapy of physician's choice, regardless of the level of TROP2 expression, be it high, medium, or low. SG was still better than chemotherapy of physician's choice. So there is no role for TROP2 expression testing in advanced breast cancer. It does not seem to correlate with who's going to drive benefit from SG over chemotherapy of physician's choice. All patients benefit from SG versus traditional chemotherapy. Moving on to trastuzumab deruxtecan and targeting HER2 low expression, you can see that we know that about 20% of breast cancers are HER2 positive or HER2 amplified. And HER2 low disease occurs in a significant proportion of patients regardless of hormone receptor status, but it does seem to vary by receptor status. About 2/3 of patients with hormone receptor positive disease have HER2 low disease, defined as an IHC of 1+ or 2+, whereas about 1/3 of patients with hormone receptor negative disease have HER2 low disease. And so this is relevant because it helps us determine who are those patients who are eligible for treatment with trastuzumab deruxtecan. Trastuzumab deruxtecan was first approved for HER2 positive disease based on the DESTINY-Breast03 trial, but the DESTINY-Breast04 trial specifically evaluated trastuzumab deruxtecan versus chemotherapy in patients with HER2 low disease. And the reason for this investigation was because TDXD has a very potent bystander effect. So the rationale was that perhaps you don't need a very high level of HER2 expression for TDXD to exert an anti-tumor activity. And that, in fact, did turn out to be the case. So in the DESTINY-Breast0 trial, patients with HER2 low disease, either IHC or 1+ or 2+, who were FISH negative, who'd had 1 to 2 prior lines of chemotherapy in the metastatic setting, so this was not a frontline trial, were eligible and randomized to TDXD versus chemotherapy of physician's choice. There were 5 different chemotherapy options available here. And the majority of patients, so 90% of the patients who participated in this trial, had hormone receptor positive disease, but 10% of patients, or 58 patients, had hormone receptor negative disease. The primary endpoint here was to look at progression-free survival in those patients with hormone receptor positive disease, but there were a number of secondary endpoints looking at PFS in the overall intent to treat population, as well as overall survival in hormone receptor positive disease, as well as the overall patient population, and then some exploratory analyses looking at PFS and OS in the triple negative breast cancer population, or rather hormone receptor negative HER2 low disease. And what you can see here is that TDXD was significantly better than chemotherapy of physician's choice in terms of median progression-free survival, demonstrating an almost 5-month significant improvement in median PFS. And in looking at the exploratory analysis in hormone receptor negative disease, you can see that there was a numerically similar benefit in median progression-free survival, favoring TDXD over chemotherapy of physician's choice in hormone receptor negative disease as well. But again, this was a very small number of patients. Only 58 patients who participated in this trial had hormone receptor negative disease. In looking at overall survival, there was also a significant improvement in overall survival of 6 months favoring TDXD versus chemo in the hormone receptor positive cohort, and numerically, again, favoring TDXD in the hormone receptor negative cohort as well. So a 10-month improvement in median overall survival here. So when TDXD was approved for HER2 low disease, the approval included both hormone receptor positive as well as hormone receptor negative advanced HER2 low breast cancer. What are some of the side effects that we see with trastuzumab deruxtecan? I think we all know these quite well because TDXD has been approved for use for HER2 positive breast cancer for a number of years. Nausea and vomiting in my personal practice are toxicities that I see a fair bit of. But again, the vast majority of patients who develop nausea and vomiting, it's grade 1 to 2 and manageable with antiemetic agents. In fact, there are some data that low-dose continuous olanzapine at 2.5 milligrams can be very effective. And I've certainly incorporated that into my practice, and it has made TDXD much more tolerable for patients. Also cytopenias, but again, neutropenia, anemia, thrombocytopenia are generally grade 1 to 2 and manageable. There is, however, a unique toxicity that is associated with trastuzumab deruxtecan, which is interstitial lung disease. And in the DESTINY-Breast04 trial, that accounted for 12% of patients. The majority of these patients were low grade. However, there were a handful of cases of fatal interstitial lung disease. So it is very important to think about interstitial lung disease in patients who develop any respiratory symptoms be it shortness of breath, cough, dyspnea on exertion. Very important to think about this. And we're going to talk about management of interstitial lung disease in just a moment. I'd also like to briefly mention the DAISY trial, which was a 3-cohort phase 2 trial, which investigated trastuzumab deruxtecan in different scenarios in HER2 positive disease, HER2 low disease, as well as HER2 zero on IHC. So a small number of patients, 37 patients. But what I'd like to point out here is that there were some benefits seen even in patients with HER2 zero disease. About a third of these patients did have a response to therapy. And so there are trials ongoing looking to see if we even need to test for HER2 by immunohistochemistry to determine if patients are candidates for trastuzumab deruxtecan. The current approval is for HER2 low disease, but that very well could change down the road. We've seen in the context of hormone receptor positive disease in the Destiny Breast 06 trial that there was benefit seen even in HER2 ultra low disease. But again, that is not an approved indication at the moment, but I think an area of active investigation. Now, I'd like to spend the last few minutes thinking about the management of some of the treatment-related adverse events that are associated with some of these newer therapies that we have available to us. I'd mentioned that with the approval of immunotherapy, we now need to think about immune-related adverse events. In thinking about these toxicities, it's very important to grade the toxicity because that does determine how we might manage the toxicity. There are a number of different guidelines, SITC, NCCN, ASCO all have guidelines on the management of immune-related adverse events. And the general sense is that we need to grade the toxicity. The more severe the toxicity, then the management varies. So for low-grade toxicities, sometimes we can just hold and watch. For grade 2 or higher toxicities, we would want to think about incorporating corticosteroids, either oral or IV, as the toxicities increase in severity. And for the low-grade toxicities, we can generally consider re-challenging patients if these toxicities resolve quite quickly. However, for those that do not, permanent discontinuation of immunotherapy may be required. In regards to the PARP inhibitors, generally these toxicities are very easily managed. Nausea and vomiting are some of the most common, and using anti-emetic agents can really help manage these toxicities. Anemia is another toxicity which we talk about a lot, but I have to say personally in my practice, I have not experienced too much of. But thinking about dose modifications or giving transfusions if patients are symptomatic can be considered here, then followed by a dose modification. But in general, PARP inhibitors are generally very well tolerated, primarily grade 1 and 2 toxicities, and generally nausea is quite manageable with anti-emetic agents or even considering dose modification. Sacituzumab govitecan, two of the biggest toxicities that we see are neutropenia and diarrhea. The diarrhea can be managed with anti-diarrheal agents. And with neutropenia, sometimes consideration for dose reduction or the institution of growth factor. I have to say personally in my practice, if it's just neutropenia that patients are experiencing, I will consider incorporating growth factor into my practice. However, if there are multiple toxicities or poor tolerability, then I do consider a dose modification as well. Trastuzumab deruxtecan in general, the toxicities that can be the most troublesome in the clinic are nausea and vomiting. And it used to be prior to the use of low-dose olanzapine, I would have to bring patients back for IV fluids and IV antiemetics, perhaps a week out from their initial treatment administration. But I found that low-dose olanzapine of 2.5 milligrams continuously can actually be remarkably effective for the management of nausea and vomiting. So that has really been quite helpful. Interstitial lung disease, however, remains a concern that we need to be quite vigilant about. that deruxtecan payload is associated with interstitial lung disease. And we've seen about 12% of patients, so 1 in 6 may develop interstitial lung disease. So we need to be very vigilant. So how do we monitor patients for interstitial lung disease? Well, obviously, a number of these patients are getting scans every 6 to 12 weeks. And so we are able, fortunately, to catch a lot of interstitial lung disease in the asymptomatic stages. And so for grade 1 toxicities, for grade 1 toxicity, which refers to only apparent on imaging, we can obviously interrupt dosing. And if the interstitial lung disease findings resolve quickly, then considering rechallenging with either the same dose or a lower dose. For those patients who are symptomatic at all in any way, they have a cough, shortness of breath, fever, some other respiratory symptoms, dyspnea on exertion, or orthopnea, then permanent discontinuation of TDXD is required. And also, obviously, instituting steroids can help mitigate the toxicities that have been seen. Because there is a risk of fatal interstitial lung disease, at the present time, it is appropriate to permanently discontinue for any patients who develop symptomatic interstitial lung disease, although there are some studies that are ongoing looking at rechallenging patients with easily managed symptomatic interstitial lung disease. But I think we're not quite ready for prime time there. We need a little bit more data in this space. So when we think about personalizing therapy for patients with metastatic triple-negative breast cancer, we have a number of biomarkers which can help us identify what strategies we want to use for specific patients. Obviously, testing for PD-L1, germline BRCA in that frontline setting are very important. For patients who have PD-L1 positive disease, the standard of care frontline approach should be chemotherapy plus pembrolizumab, because we know that strategy is associated with a significant improvement in overall survival. For patients who have germline BRCA mutations, olaparib and talazoparib are both approved for use and have been shown to be more effective than chemotherapy, a physician's choice, and in addition are associated with a better quality of life. So those would be appropriate strategies for patients in the frontline setting who have BRCA1 and 2 germline mutations. If patients have both PD-L1 positive disease as well as a germline mutation, I do start with pembrolizumab-based therapy because, again, there's a survival advantage that was seen in the Keynote 355 trial. There was not a survival advantage seen with olaparib and talazoparib. So I think in that frontline setting, I would generally favor starting with pembrolizumab-based therapy. For patients who do not have a germline BRCA mutation and have PD-L1 negative disease outside of a clinical trial, the standard of care is standard of care chemotherapy. So taxanes and platinums are generally used in that frontline setting. And then moving on to the second line setting, we have sacituzumab govitecan that is available for use. And this is approved for patients with all forms of triple negative breast cancer, regardless of the presence of any biomarkers. Does not require TROP2 positivity because, as you saw in the ASCENT trial, we saw that SG is better than chemotherapy regardless of TROP2 expression levels. Trastuzumab deruxtecan is also approved in that second line setting for patients with HER2 low disease, either IHC 1+ or 2+. But again, this only occurs in about a third of patients with hormone receptor positive disease. So only about a third of our triple negative patients are going to be eligible for trastuzumab deruxtecan. Now, moving on into that third line setting, again, we could consider using TDXD if patients are candidates here and they've received sacituzumab in that second line setting. Number of other biomarker-driven therapies. If patients have mismatch repair, microsatellite instability, high tumor mutational burden, could consider therapies here. Although I would say for many of these therapies, I would consider those upfront in the frontline setting because we know immunotherapy is going to be more effective in the frontline setting than in subsequent lines of therapy after the immune system gets a little bit more beat up by chemotherapy. So really in the third line and beyond settings, we're looking at traditional chemotherapy agents, platinum-based therapy, eribulin, carbo, gem, if not already given, capecitabine, vinorelbine. So again, the efficacy of these agents, however, after disease progression on antibody drug conjugates remains to be seen and is likely not great. And so certainly clinical trials would be options for patients here as well. And then future strategies, we have a whole host of antibody drug conjugates that are in development. Datopotamab deruxtecan, which is another deruxtecan payload containing antibody drug conjugate, targets TROP2, similar to SG. And then patritumab deruxtecan, which is a HER3 targeting ADC, is also in clinical trials, as well as agents targeting a whole host of different antigens on the surface of cancer cells, including LIV1A and others. So again, I think the future is very bright and holding a lot of promise for us with subsequent antibody drug conjugates. I'd like to end just a bit about raising awareness of breast cancer in the Black community and some of the work that's being done as part of this program. We know that triple negative breast cancer is more common in Black women and even Hispanic women. And we also, unfortunately, know that Black women have the highest likelihood of dying from triple negative breast cancer. They have the poorest overall survival as compared to other racial and ethnic groups. They also have a higher likelihood of developing early onset breast cancer. And so there are great disparities that exist in the management of breast cancer, including triple negative breast cancer, where we know we have a large proportion of Black women diagnosed with this form of breast cancer. And so there's an urgent need to help improve outcomes for our Black patients with breast cancer. In a registry study of over 2,000 women with breast cancer, we found that there were almost 200 patients diagnosed with triple negative breast cancer, and 40% of these patients were self-identified of Black race. Overall, we know that triple negative breast cancer is more common in Black women than non-Hispanic white women. And we also know that those individuals who live in disadvantaged neighborhoods have the poorest prognosis. They're more likely to be diagnosed at later stages of disease and have higher death rates. And so again, it's important to recognize these disparities so that we can then start to tackle them. Here is a study looking at breast cancer specific survival in women with triple negative breast cancer. Again, just showing us what I've already told you, that Black women do more poorly than white women. They have poorer survival. And so again, there are a lot of reasons behind this. And I think there have been a number of studies that have demonstrated this over and over again. So when we think about what underlies the disparities in outcomes in triple negative breast cancer, it's important to recognize that this is multifactorial. It's not just one thing. We know that socioeconomic factors can certainly factor in poverty, financial toxicity, decreased health literacy, lack of insurance, lack of access to care, I think are huge factors which we as a healthcare community need to figure out how to tackle and approach and make sure that our patients are getting equal care. We've made some remarkable advances in the management of triple negative breast cancer in the last few years, and we need to make sure that these therapies are getting to all of our triple negative breast cancer patients equally. We also know that there are historical factors such as cultural practices, a lack of access to trials, mistrust of the medical community. These are all things that we need to make sure that we're approaching our patients equally with these newer therapies. We know that there are biological factors such as obesity, disparities in mutational testing that can impact outcomes. We need to make sure that all of our patients are getting access to testing for PD-L1, for BRCA1 and 2, and other factors which could help us identify better therapies for the management of these different triple negative breast cancer subtypes. And then it's also very important to recognize bias in the healthcare system, implicit bias, systemic bias, and patients who may be unwilling to seek care because of a past history of discrimination. So again, it's a multifactorial process that's going to take multifactorial improvements in care to deliver equal outcomes for all of our patients with triple negative breast cancer. So what are some of the interventions that are being done as part of this program? Obviously, social media is huge. Getting out into our Black communities, making sure that Black women know that they're at higher risk for developing triple negative breast cancer, making sure that patients are getting screened, have options for healthier lifestyle choices. I think, the educational initiatives that we're launching as part of this program are designed to help raise awareness among Black women of breast cancer risk and ways to seek care to get their therapy that they need. So with that, I'd like to end with a few case discussions. Our first case is a 38-year-old woman who was diagnosed with an early stage triple negative breast cancer. She received neoadjuvant chemoimmunotherapy as part of the Keynote 522 regimen. So paclitaxel plus carboplatin followed by AC, given concurrently with pembrolizumab in the neoadjuvant setting, and then continued in the adjuvant setting as well. At the time of surgery, she was found to have a 5 millimeter focus of residual breast cancer in the breast only. Her lymph nodes were negative. She went on to receive adjuvant radiation therapy, as well as completing a year of pembrolizumab. Unfortunately, 3 months after she completed therapy, she was found to have a local recurrence in the chest wall. She had a biopsy of one of the lung lesions that revealed recurrent triple negative breast cancer. It was PD-L1 negative and HER2 0. She had genetic testing and was found to have a germline BRCA1 and 2. And found to have a BRCA1 mutation. She received olaparib in the frontline setting and had a response for a period of time, but unfortunately 6 months later was found to have disease progression. So what would be the most appropriate second line treatment for her? Would it be pembrolizumab plus paclitaxel, trastuzumab deruxtecan, sacituzumab govitecan, talazoparib, or capecitabine? So I, in this second line setting, think that C, sacituzumab govitecan, would be the best option for this patient. And that's because we know from the ASCENT trial that sacituzumab govitecan is better than chemotherapy of physician's choice. It was associated with a significant improvement in median progression-free survival, as well as overall survival. Choice A is not an appropriate answer because this patient has PD-L1 negative disease. She is not a candidate for pembrolizumab. Choice B is not a good answer because she had HER2 0 HER2 0 on IHC, and trastuzumab deruxtecan is only approved for HER2 low disease. There is no data that suggests using one PARP inhibitor after another in individuals who've got BRCA1 associated breast cancer. So D, talazoparib, would not be a good choice. And capecitabine is not a good choice because we know that sacituzumab govitecan is better than chemotherapy of physician's choice. So again, in the second line setting, in an individual with a PD-L1 negative disease who's already received olaparib for BRCA1 associated advanced stage disease, sacituzumab govitecan would be a best choice. So moving on to case 2, this is a 62-year-old woman who presented with de novo metastatic breast cancer to the liver. A biopsy revealed hormone receptor negative HER2 low disease. Additional biomarker testing revealed that she had PD-L1 positive disease, and genetic testing revealed a germline BRCA1 mutation. She went on to receive nab-paclitaxel plus pembrolizumab in the frontline setting, but unfortunately, after a year, experiences disease progression in the liver. Which of the following therapies would you recommend for this patient in the second line setting? This patient has PD-L1 positive disease and has progressed on pembrolizumab plus chemotherapy and also has a germline BRCA1 mutation as well as HER2 low disease. Would you select talazoparib or olaparib, trastuzumab deruxtecan, sacituzumab govitecan, or capecitabine? This answer has a number of excellent options for this patient. However, given that she has a germline BRCA one mutation, talazoparib or olaparib is a very reasonable treatment to give in this next line setting. We know that both talazoparib and olaparib are associated with an improvement in median progression-free survival as compared to chemotherapy of physician's choice and are associated with an excellent quality of life. While the patient is also eligible for trastuzumab deruxtecan, as she has HER2-low disease, and sacituzumab govitecan, I think these are therapies that could be reserved for the subsequent lines of therapy, given that they have been shown to be effective even after disease progression on other therapies. Capecitabine would not be a good choice, as we know that both PARP inhibitors as well as antibody drug conjugates are better than capecitabine. So just to summarize some key takeaways from this talk, we know that triple-negative breast cancer accounts for about 15% of all breast cancers and has a tendency to affect those who are younger, those who are Black, and those who are Hispanic. There are a number of biomarkers that are appropriate to test our triple-negative breast cancer patients for to see if this could help guide clinical decision-making. For those tumors that are PD-L1 positive, defined as a combined positive score of at least 10, we know that pembrolizumab plus chemotherapy is an appropriate option, as this combination is associated with a 7-month improvement in median overall survival. For those individuals with germline BRCA1 or 2 mutations, olaparib and talazoparib are options as well. For HER2-low disease, based on the Destiny Breast 04 trial, we know that trastuzumab deruxtecan is an excellent choice and is associated with a numerical improvement in median progression-free survival and overall survival as compared to chemotherapy of physician's choice. Sacituzumab govitecan is available for use in the second line and beyond setting for all forms of triple-negative breast cancer, regardless of TROP2 expression levels. We know that the vast majority of toxicities that have been observed with these agents are low-grade and manageable. They can be managed with supportive care, including antiemetics, antidiarrheal agents, and growth factor, and dose modifications as well. Interstitial lung disease is a very important toxicity to recognize in the context of trastuzumab deruxtecan therapy, and we know that up to 12% of patients can experience some interstitial lung disease. It's very appropriate to catch these patients early when therapy can be given to hopefully reverse and prevent any further decline in pulmonary function.
Thank you so much for being with us for our presentation. We also want to thank Dr. Nanda for your contribution.
I'd like to thank you for participating in this educational program and for spending your hour with us.
Please remember to complete the evaluation shown on the console to claim your education credit. For more information, contact us at info@dkbmed.com. Once again, I am Tabitha Washington, and I've been happy to serve as your host for this session.